Good morning, everyone. My name is Marlene Saunders, and I am chair of the project's Community Advisory Council. And just like Gregory and Lee and Omar, I too want to offer a hearty welcome to you all. I am especially pleased about the panel that we have been able to pull together for today's program. We have an esteemed group of health professionals, as well as community activists, who will be able to demonstrate and highlight the importance of collaboration between community, researchers, scientists, physicians, and others to identify solutions to problems that impact the well-being of communities, particularly those about whom we are talking about today. Just for a little background information, the Community Advisory Council role is advisory and collaborative with the project. The council aims to clarify best approaches to solving health problems, reach people statewide with new research and information, and build connection for research in the broad community. Now it is my pleasure to introduce our moderator and our panelists for this morning. Dr. Kara Odom Walker is Senior Vice President and Chief Population Officer of Nemours Children's Health System. Dr. Walker leads the Nemours National Health Office, Advisory and Public Policy, as well as all aspects of population health strategy, research, innovation, and implementation. Her scope of responsibility includes advancement of the overall health and well-being of children, both broadly and among the population served by Nemours. From January 2017 to 2020, in August, Dr. Walker served as Secretary of the Delaware Department of Health and Social Services under John Kerry. Next, Ms. Laveda Owens-White is a master's level registered nurse who has more than 40 years of nursing experience in acute and long-term care, rehabilitation, home care, and community health. She is currently working in the practice setting of Faith Community Nursing and as coordinator for the Delaware Region Health Ministries Network. Ms. Owens-White is a faculty educator for the International Parish Nurse Resource Center and instructor for the Foundations of Faith Community Nursing Core Curriculum. As a community activist and life member of the NAACP, she is active in leadership positions in community-based. As a community activist and life member of the NAACP, she is active in leadership positions in community-based associations. One of her current interests is in nursing research, exploring a collaborative partnership of community and faith-based organizations in addressing childhood obesity. Next, Dr. Marshalla Lee is a board-certified family medicine physician and the director of the Heritage Value Institute Community Partnership Fund at Christiana Care. She also serves as the lead physician at Shortridge Academy School-Based Health Center, sponsored by Christiana Care. She is responsible for strengthening community partnerships, mentoring pre-medical students from underrepresented backgrounds, and developing new models of patient-centered healthcare that address the social determinants of health. Dr. Martin Luda heads the Bureau of Communicable Disease Prevention within the Delaware Division of Public Health. The Bureau comprises several programs providing core public health functions, including disease surveillance, disease investigation, coordination of prevention and treatment activities, public provider education and training, regulatory public health activities, and policy development. Dr. Luda has over 15 years' experience in public health administration. One of the programs under his portfolio is the immunization program. Finally, Ms. Rosa Rivera is Chief Operations Officer for the Lorette Health Center located in Georgetown, Seaford, and Milford, Delaware. Ms. Rivera has spent the last 30 years plus working with the underserved communities in Delaware. A hands-on person, she loves the opportunity her job provides to directly interact with staff and patients. Dr. Walker, I turn over moderating the panel to you.
Thank you so much for that warm introduction. And it's so wonderful to be with everyone today in the audience. If we were in person, you would hear roaring applause for our fantastic panel that we've started. I'm looking forward to this conversation and thought that what we could do to get us started is just reflect a bit on each of our individual roles and a bit about major barriers and issues for engaging the community. And I know this is something that Nemours is thinking about every day, and how we really address the needs of our community, how we think about the pandemic and how it's shifted priorities, and how important it is more than ever that we make sure we're thinking about things from an equity lens. So I'll just go down the panel and everyone can share a bit about their background, their role, but also a bit about where you see us moving forward. And so I'll just first start in the order that Dr. Sanders introduced, and start first with Ms. Owens with Levada, if you don't mind starting us off.
Thank you. It's very, very, very nice to be here with all of you today. And I'm certainly excited about the keynote speaker that provided us with such great information, because there is some hesitancy around getting the vaccine. And so I have been fielding questions from my community groups about how we can go about being intender as opposed to wait and see. So this has been exciting for me to be a part of this very extensive conference here today. So from my background, just getting the message out about the vaccine and the importance of protecting ourselves and our families has been the most important thing that I have been doing, because there has been a lot of questions around the speed, the rapidity of the vaccine coming out and the safety of it. So having this information to provide to the community with expert presenters and having the science to back it up has been incredibly important for me.
Thank you so much, Levada. You're right. I mean, more than ever, we have to start thinking about things from a community lens and how we get accurate information out. I'm going to use first names. I hope that's okay. We all are bringing our important perspectives to this, and start with Marshalla.
Good morning. Thank you so much for including me on this very important panel. I am a family medicine physician at Christiana Care, but more importantly, I think is working as a community partner to strengthen our community relationships. And so it's amazing to believe that we've been dealing with COVID for almost a year now. And we all had plans this time last year about the important work that we were partnering and planning to address. And so at Christiana Care, we were in the process of developing a barbershop hypertension initiative, and it was due to go live this summer. But unfortunately, due to COVID, we had to and immediately convert our project to meet the immediate needs of our community. And so COVID-19 has shown us that we oftentimes don't have a year to plan things, and that we must be in tune to the community in order to meet their needs and be flexible. And so I look forward to sharing more information with you today about the work that we're doing at Christiana Care and strategies for increasing equity in the vaccine distribution process.
Thank you for all you do. Martin, would you share a bit about your perspectives and thinking? Who knew that your role would become so important right now in the time that we're in around vaccines?
Right. You could have said that better, any better. And thanks again for including me in this panel. I think it's a very important discussion. My background is in pediatrics, and with that in mind, promoting vaccination and the understanding of the diseases that they prevent is something that I've grown up with in medicine, and I've continued to do that in public health. So what we are doing right now for COVID-19 is not very different from what we do for vaccines in general on a daily basis. It's only the difference is only the scope and the rapidity of the development and the severity of the whole situation. I think as Dr. Fan, I think one of the earlier presenters did indicate earlier that the when she was talking about the levels of healthcare engagement, especially pediatric healthcare engagement, how it initially dropped and then kind of came back up as the months rolled by. That's something we tracked in public health very closely, because initially we were very concerned about the drop-off in routine pediatric vaccinations that happened as the COVID set in, and all the social distancing and all that, all the issues that pertain to that affected healthcare and how practices operate and how patients present. We were worried that we may actually see something added to the back of the pandemic, which is other childhood vaccine preventable infections coming on board. We're happy to say that, as Dr. Fan indicated, everything seems to have come back to fairly normal. There's still fluctuations, but we are seeing fairly good catch up in routine pediatric vaccinations. So that's the good news. The news that's not so good, of course, is the COVID itself. Just like with other vaccine preventable infections, we have to convince the public that it is a serious disease. Luckily enough, I think the media has done that for us, so we don't have that much of a task to convince folks that it is a serious condition. What we have been struggling with is the acceptance of the vaccine, and as what some of our presenters did show, there were some disparities, some racial disparities in acceptance. This may, my personal belief is that as the vaccine becomes more readily available and more people accept it, that hesitancy might actually drop off. And also there's also been, of course, the vaccine accessibility. As that improves, I believe that the acceptance across racial groups might also improve. So some of the things that we are addressing as public health, and of course, it's a constantly evolving situation. So there'll be a lot to discuss later on in the season as opposed to now. I think I'll cut off there for now. Thank you.
Thank you so much for that overview. And you're right, we are seeing rapid changes in vaccine hesitancy through just role modeling of others getting the vaccine, and then what's happening in our communities through both formal and informal channels. I hope we'll talk about that more. Right. I wanted to now ask Rosa to give some perspectives from the work that you're doing on the ground as well.
Good morning. Thank you for allowing me to be here. It's an honor to be part of everything, individuals in this panel. I was amazed listening to the keynote speaker that actually was able to validate some of the things that we are actually seeing and some of the responses that we're hearing from the communities that we work with. So it's not good because we don't want to hear it, but it was kind of validating some of a lot of the things that we have seen and are working through. And at Lorette, we obviously have a trusted, I would say, communication with our communities that we serve, which has helped us in reaching out. I said that probably the engagement with some of the organizations in the community, working with the state, working with public health, working with the hospital, has allowed us to increase that reach out that we've been trying to do and validate a lot of the things that we're doing. With the start of the pandemic, I think that what was clear to us was we always known the challenges, right, that our communities faces, whether it's transportation, housing, work, through communication, information, but all of that was really magnified by this pandemic. And even though we knew these were issues, it was it was clear to how big of an issue these things were really at, and how we quickly had to change some of the things that we were doing to really get out of our comfort zone, right, and get out there and do some of these things. So that was kind of like a roadmap for us to say, okay, how are we going to engage, right, our patients in terms of getting vaccinated? Because we're going to face the same issues. We're going to face transportation. We're going to face the work issues. We're going to face the education. We know that there's a lack of radio, television in the languages that our patients are best served on. So they tend to use social media a lot to get their information. And so there's a lot of miscommunication and myths out in the social media, but this is what they're listening to, this is what they're hearing, and we have to kind of dissipate some of that. So I think the important key for us is knowing that the vaccinations were coming, and this was going to be key to the success of getting our community back to normal was so important to them, was asking the question, once it's available, would you receive the vaccine? And if the answer was no, then trying to figure out what were the concerns, why not? Not just documenting no, but why not? What is stopping you from receiving that vaccine? And then try to understand and acknowledge that concern, not kind of push it out, but kind of acknowledge that concern because it was real. It is real to those individuals. So therefore, despite of our knowledge, despite of our wanting to get them vaccinated, we need to first accept their concerns, try to address them, and then give them the space that they need to make that decision. So they're not feeling that we're pushing them to do something, and then that's going to create more of a negative attitude. So those were some of the, and then documenting that and doing a follow-up with clinician, depending on what those concerns were for our patients. So those are some of the things that we're trying to work around to try to get more individuals lined up to get vaccinated.
Thank you, Rosa. We have an incredible panel. All of us are doing so much every day in our roles, both formally and informally. I think one of the challenges with vaccine distribution is how do we bridge the divide between our patients as providers providing routine care and also managing chronic disease in the midst of thinking about COVID-19 vaccine distribution. I thought we'd first switch gears a little bit and think about some of the challenges around equitable distribution of the vaccine for COVID-19. We know in the state, we have dashboards to help us track it, but it also has to trickle down to what's happening in our hospital systems, our clinics, our patient panels. And so hope that both Marshalla and Rosa, you could talk a little bit about some of those challenges around equity. And I think you've touched on this already. I'll go back first to Marshalla to share a bit of her background and perspectives.
Yes, and so this is where training that we've been accumulating for a while really came to handy with COVID-19. In addition to being a family medicine physician, I obtained my master's in public health with a concentration in healthcare management and policy with a focus on minority health policies and disparities. And so this background has come in handy. Mitigating disparities in vaccine administration will require us explicitly prioritizing equity to ensure that communities with the highest COVID-19 risk get vaccinated. Health systems, I really see us as being extra hands and boots on the ground. We are typically trusted partners in our communities, and we must work in partnership with our departments of health and local communities to increase education, trust, and access. I'm not sure if you guys have seen it, but the National Academies recently released a publication which describes a framework for equitable allocation of the COVID-19 vaccine. We have to remember there is no one-size-fits-all approach. Early on, people were asking for easy, simple answers and fixes to get the vaccine to our communities. Unfortunately, there's no easy answer. However, we must ensure that our distribution plans include equity. They must explicitly include equity, because if not, there's the potential to exacerbate major health disparities that we're already seeing. Many state plans have implemented online appointment systems, which is very problematic. The process of making an appointment to be vaccinated requires substantial time, technology, and trust, as we mentioned, due to the hesitancy. And we already knew that going to COVID-19, that resources are unevenly distributed in much of the United States population. We have been thankful at Christiana Care to work in partnership with the state of Delaware. We recently hosted a community vaccination event for elders from communities that have been most affected by COVID-19. And we had the opportunity to partner with Nurse Owens White. So thank you for that partnership. But in developing our planning and our distribution processes, we know that it's important to partner with local healthcare institutions, community organizations, and other trusted partners. We prioritize vaccine distribution to zip codes that have been most severely affected by COVID-19. Not only did we prioritize those communities, but we chose a community site outside of our hospital walls that was more convenient to the community that we were serving. So we have to be willing to go to underserved communities and individuals who face mobility or other transportation barriers. This requires us to be creative and possibly be uncomfortable. We also simplified our registration procedures and only collected via telephone the minimum level of information required for pre-registration and allow individuals to provide the additional information on site. And that required a lot of trust. And what we did was we partnered with community organizations to assist us with registering people, because we knew that they had already established relationships with those communities and they would be more willing to register. And thankfully, with the communities that we've been interacting with, I haven't encountered much hesitancy. And I think largely that's because the messenger matters. The messenger matters. The messenger must be willing to validate communities' concerns and show empathy for their reluctance and fears. The providers must be culturally competent and understand the health needs and challenges of their communities. And this is also why it's so very important that we diversify our health workforce and invest in our local health workforce pipelines, so that we have physicians and health providers that are familiar with the needs of the communities that they serve. And lastly, we're using data to help drive our vaccination efforts. In real time, we're monitoring disparities in the community as well as disparities in distribution. And so those are some of the things that I think the health system can do in partnership with our community and departments of health. So thank you.
Thank you. Rosa?
I think in our case, doing many things to validate Dr. Lee had said, but we have a very diverse staff at Lorette. So to us was staff first. So how do we get our staff, right, to say, yes, this is something we want to do. We want to be vaccinated. Because if you can get your own staff on board, you can get your own providers on board, you can get your nurses on board, then it's going to be even more difficult to get your patients on board. So that was very, very important to us, to be able to say our staff is getting vaccinated and they're going out in the community and say, yes, I got my vaccine. So our medical director, our fabulous medical director, Dr. Alakan, did a fantastic job on meeting with the staff, talking with them individually, trying to address their concerns, and getting those nurses and healthcare providers vaccinated. So that was first to us. Like I said, our staff first. And then learning from us, as I previously said about the testing, transportation we knew was going to be an issue. Well, we had stopped transportation because due to COVID, it was not safe to transport, right? And there were some safety issues. So we looked for funding. We were able to get new vans retrofitted with, we have, safety for our drivers, safety for the patients that are being transported, change our protocols around transportation so that the patients felt safe. And then we knew we were going to try to eliminate that transportation barriers to get patients in for vaccine. The same with registration. There was some challenges with the testing because patients were being asked to provide an ID in order to be tested at the beginning. Well, their name and their ID sometimes didn't match by a middle name, and they were turned away from some facilities because the middle name did not match. So we knew that so was a challenge. So trying to eliminate some of those requirements and be able to fast get that information over the phone and then validate some of that later when we are comfortably sitting with the patient has also helped, because that was also a big issue. The language barrier that we have tried to address. Not only do we have a large Spanish speaking community, we have a large Haitian community that speaks Creole, and then finding interpreters and making those providers available as well. That was key to us as well. The other piece that we found that we've been working with is that a lot of our patients work not one job, but 2 jobs. So Saturdays may not be convenient for them. We said, let's think non-traditional hours. Well, Saturdays for them is not non-traditional hour. That's part of their work schedule. A lot of them work 2 jobs. So evenings may not work either. So maybe we're looking at a Sunday to do and make things available. So we had to kind of work around that and be able to accommodate that workforce and how we get them in here. One of the challenges that we're seeing in terms of vaccinating is that we don't have, and when we talk about equity, we don't have a large number of Hispanics or Latinos over the age of 65 within our population. So we're struggling there a little bit because that's not a large proportion of our patients. So, but we're still reaching out for those under 65 to get them ready and so on. But it's going to be key to us, as Dr. Lee mentioned. It's not just what we're going to be able to do within our walls, but how we're going to partner with our churches, and how we're going to partner with the other nonprofits, and how we're going to partner with some of the local employers, right? And partner with them and maybe go to the facilities to be able to vaccinate. That's going to be key as well. So understanding that not everything can be done within our walls, and we have to go into our communities, and we have to be prepared to do that. The workforce has been also a challenge in terms of enough staff and prepared staff to go out and vaccinate. So that's another challenge. As mentioned before, our providers and our nurses are already doing everything else that they do every day. So we're throwing this on top of that, and it can cause some burnout. So we're also looking at how to make sure that we keep a healthy staff, right? Both physically and mentally, so that they're prepared and willing to do this. That they see it as an opportunity and not as a punishment or a challenge, right? But how do we provide those resources to them so they feel comfortable going on in our communities and doing what they do best, which is care for our patients.
That's right. I think we have to think about how to approach our patients in unique ways, and love the comment around thinking about provider racial concordance, because we know that often matters. Language concordant, racial concordance has mattered for a long time in addressing ongoing health disparities and challenges in overcoming those. I wondered if you could talk a bit more about both of the prongs and roles that you play in terms of the medical and the public health community taking on equity, specifically around vaccine. Are there ideas, recommendations that you think would be helpful to ensure that we are adequately achieving equitable distribution of vaccine? And I think some of that is the engagement, but there are other ideas floating out there around navigating the IT barriers, the workforce challenges, embedding services in communities that you've mentioned. I wonder if you have other comments along that. And Rosa, I'll have you go first this time and then go back to Marshalla.
Well, we also know, yes, that IT has been a big challenge on how we reach our patients. We learned, it was interesting that we learned through the pandemic as we moved to telehealth. One of the interesting things, and we were working with our patients to transition them to video visits, right, and so on, that a lot of our families have one phone and they share that phone, right? So when we were trying to reach our people, well, the husband maybe had the phone at work and the mother didn't have the phone at home to be able to do that visit. So communications became a real struggle in terms of us also calling our patients to remind them or get the education done. They tend not to answer the phone during the day, and we find out that we will get a amazing amount of calls either after 5 o'clock or during lunchtime because our patients were working. So communication and being able to reach our patients when they're ready for us to reach them was an issue for us. Learning what was the best times and the best days to reach out to our population. In terms of I think right now, I guess the challenge that I see when I'm working with my patients is that we have many patients that are ready, but we're not ready because they don't fall where they need to. And I believe, at least for the direct communication that I have with my patients, is they're waiting for that number to go up. Let's say we're waiting for more Hispanics to be vaccinated. We're waiting for more, African Americans to be vaccinated. Well, because they're not in those numbers that we're currently vaccinating, we don't see that percentage going up. They're not willing to move because they're not seeing that number. So my struggle is, we need to vaccinate those that are ready to be vaccinated within these groups that is so challenging for us to reach out. Because I truly believe that when we start vaccinating those that are willing and ready to be vaccinated, whether they're 65 over or not, then that's going to move those that are in the not too sure bucket over to, I'm going to go ahead and get vaccinated. So I just hope that that time comes sooner than later, that we are able to start vaccinating those that are ready, so that we can see that impact that I really believe is going to come right after we do that.
I agree, Rosa. In many ways, I think that there was maybe even too much attention that was placed up on the hesitancy part as an explanation for why more minorities weren't being vaccinated, because I hear more individuals saying that they want the vaccine now and are having difficulty accessing it. So I hope that we put more effort and attention towards equitable distribution and those creative plans than trying to overcome the hesitancy. Because as you say, I think as more people get vaccinated, their loved ones get vaccinated, they have good experiences with the vaccine, they're then more likely to get the vaccine. So regardless of what the messenger says, I think there's no better way to convince them that it's safe than to actually have a relative or loved one that gets the vaccine and that they have real time and real knowledge that it's safe and effective. And so what we've been doing is working with different community leaders. We're going to have have to have boots on the ground. So social media is great, but we know that the campaigns eventually need to have some door knocking components, and that there are not enough physicians, enough researchers that are able to do that. So we've been working to educate our community partners, answer their questions, because we know that we're going to need their assistance with being the door knockers and the boots on the ground, and also having more intimate conversations. Sometimes people are uncomfortable expressing their questions and their hesitancy in large setting. One thing that I do when I start presentations is that I acknowledge the fact that I was hesitant. When I heard Operation Warp Speed, I told people, I don't plan on getting that vaccine anytime soon. And so, but I knew that as a community advocate, as a trusted partner, that if I didn't get the vaccine, if I wasn't willing to get the vaccine, that I couldn't convince others to get it. And so I use my life as a opportunity to say, hey, I'm afraid, but I'm willing to sacrifice. And I saw the data, but I'm willing to sacrifice and ensure that it's safe and effective so that you'll be willing to get that as well. So it's important that providers also express their concerns and questions and are relatable. And that allows the community to calm some of their fears. So I think we really have to focus on the strategy for getting the vaccine in the community, and the hesitancy will eventually decrease.
I think that's such an important role for all of us to play in thinking through the community strategies and outreach that's needed. Leveda, I hope I can pull you into this part of the conversation, because we know that whether it's information, helping people navigate IT barriers, or just having those trusted people virtually or in reality knocking on doors is so important. I wonder if you want to share a bit about the role that community can play. And I know this audience thinks hard about community engagement and how we kind of level out those inputs in our research questions, but also how we're thinking about COVID-19.
Absolutely. One of the things that Dr. Salmon pointed out was that communities vary. So you really have to target your message to the community that you're serving. As a community activist, I am associated with the NAACP and the Interdenominational Ministers Action Council and the Interfaith Clergy Coalition in the community, trying to get our messages out to congregations and those communities that may be under-resourced and don't get the message out. I'm really excited to say that our NAACP has been doing some Zoom presentations, trying to overcome some of the reluctance that may be. But as you mentioned, that as we get the information out, more people are accepting and try, particularly those with underlying conditions, or trying to protect themselves and their families. So they're the 65 plus age group is really consistent about trying to access the vaccine. In some communities, we're still trying to get people to do the testing, COVID testing, providing the curative trailer events so that at least folks will know their status. So again, that's really something that we need to tailor to each population that we're serving. And one of the things that we try to do is ask individuals, have you been tested? Do you know your status? Why aren't you wearing a mask? Are you washing your hands? All those things. And then we're trying to get clergy to import that message to their congregations as well. I was privileged to go on one of our congregation's television show, and the response was overwhelming to the pastor. There were many questions that came up that wanted to be answered. I'm also a part of a sorority of registered nurses, so we're getting the message out, going to high rises, providing the information that the community is asking. So those things that are important, there's a great desire for knowledge. And I think our Zoom meetings, they're two being presented by the NAACP and also a congregation down in Sussex County. Reverend Rita Page is doing on the 22nd, and the Newark branch of the NAACP are providing this information out to the community. We're doing COVID testing, antibody testing. So those are the things that we're trying to do to protect our community.
Thank you, Olivia. I wonder if you could also talk about some other ways to overcome those IT barriers. You know, some who, as Rosa mentioned, may not have easy access to appointment systems, or trying to figure out how to navigate where the information is coming. I wonder if you have other lessons that you've seen that have worked, that are effective, that are maybe a little innovative, that others should pick up and help you carry forward into other audiences.
A lot of people have their cell phones, so they're using their cell phones, and then we just more or less guide them to the different sites that they need to get onto and help them to navigate that, and particularly with congregations that have health ministries in them, they're doing helping them with their tablets, and certainly we're getting our children to help also with the technology, encouraging the parents and grandparents to ask your kids. They'll help you out, and those are the things that we're encouraging our families to do, individuals. Technology, and I could say that I'm included in the technology part, because what I don't know, I always look for someone younger than I to tell me what's up with this.
Thank you, Olivia. Martin, I'm hoping we can also ask you about where that intersection is around both the innovation of what we know about vaccine strategies, and also how COVID has changed some of the outreach strategies, and hope you could comment a bit on the perspectives that were shared by the other panelists.
insightful comments into some of the issues that we face. DPH, the Division of Public Health, is data driven. So from the onset of the vaccination program, we set out to make sure that we gather data on racial and ethnic groups to make sure that we address these issues of disparity. And as of now, the trends seem to suggest that there is disparity with the non-Hispanic Blacks and Hispanics being vaccinated at lower levels than whites. However, the data at this point needs to be taken with some caveats, in the sense that I think, Rosa, you made a very good point when you said that you don't have many Hispanics over 65. So if you look at that comparison, you may find that there is a disparity, but it's really more of we are not looking at oranges and oranges, we are looking at oranges and apples, because the populations may be inherently different when you're looking at those particular categories. And the same thing applies to healthcare providers. I think because the vaccine was released in phases targeting various groups, it's obvious that vaccinations will occur at rates driven by the representations in those groups. So until such a time that the vaccine becomes universally available, I think racial data will have to be taken with that in mind as well. But the messaging of the vaccination has remained fairly consistent, and we think that the approach that public health is taking in working with community-based organizations, getting closer to those populations as much as possible, to ensure that we work with folks that the community trust. I think historically there has been some mistrust for government within certain communities, and if we can work with the groups and stakeholders that these groups trust more than the government, it will of course increase the trust level for vaccination in those groups.
Thank you, Martin. Yeah, I know when I started as secretary in 2017, we had this vision of achieving better racial profiles on a range of outcomes, right? Reducing those disparities, achieving equity across the board, and surprise, COVID hits and you see this potential widening that was going to exacerbate many of the disparities we had been working on aspirationally for quite some time. This isn't new, right? We know disparities exist. We've known disparities existed in vaccination for whether it's for children, adolescents, or adults. But certainly thinking about COVID has allowed us to refocus our energy. And I wonder if, Martin, you might talk a little bit about, what is unique about this COVID era that we're in, to think about elevating the need around equity, around thinking about new models. Why did it take COVID for us to become so attentive? And I'll start with you, and then maybe the other panelists can also comment on what, again, about COVID, about this moment in time is so critical for us to think about equity in our outcomes.
Right. I think that in many aspects, COVID has been a unique experience for most of the public, because for the very first time, folks were forced to stay at home, do nothing, and watch TV, and so they saw the news, they saw the impact, and everybody saw those refrigerated trucks waiting for bodies as temporary morgues outside hospitals. We saw all the folks that were struggling to breathe while on respirators. I think it allowed everybody to focus. And when the news started trickling out that the communities of color were being more impacted than others, it was there for everybody to see. And I think that for once drove the impact of disparities, which we know has been there. It's what public health breathes and works on every day. But for the public to see this so graphically, I think has elevated the disparities discussion to a higher level. And of course, as the as the pandemic rolls on, more and more people are not only knowing folks that have been affected, but there are folks that their families are affected. And if you come from a community of color, it drives that the need for answers and the need for access to mitigating factors even more. And I think that's one of the reasons why disparities has become more of an issue with COVID than with most other situations where disparities also exist.
Veda, you've been a lifelong champion of equity. I wonder if you can also highlight what you think is unique about COVID.
Well, since it's been 15 years since Katrina struck, and we're looking at, there's not been very much of a change since that time. We're still, the people in Louisiana that was most affected by that disaster, that climate disaster, is still going through some changes that are overdue. And I think for health systems to achieve any kind of health equity, it needs to make health equity a priority. And it has to address the multiple determinants of health. And we need to build some kind of structure to support the health equity and partner with the community to improve it. You can learn, the healthcare system can learn from us what is needed in order to provide that. Sometimes I heard that, it's your complexion determines your right to services and to support. That if you're the right color, then you can get what you need. If you're not, then you might have to wait a while. So we need to identify our health problems. We need to address the racism and address these problems. Black Lives Matter brought it out very much. Now we have some attention focus. But before that, again, people are across the country in Black and brown communities are suffering this. Sorry, I knew he was going to do that. While we're trying to, make it. And we talked about the resiliency of the community. Why is the rural community much less affected? What is the stress level? We have, through this, the whole conference, we haven't talked much about the spirituality of our people, that we've gotten over so far because of our faith. And we need to investigate the importance of that with the COVID impact, because we've had to rely on that. We can't rely on government. In some cases, we can't rely on the medical community because they haven't invested enough to get to know us.
Thank you, Laveda. And it has been a moment for us to have a reawakening around race in our country, and acknowledging that racism alone is a public health threat, a health risk in our systems is critical. And I think many are trying to reorient. I know Nemours is on that journey of trying to make sure we're reorienting, not just internally for our patients and documenting health disparities, but actually taking it on in a new, re-energized, vigorous, rigorous way with metrics and efforts to engage. But it's a journey. And I think you're right. We have to reinforce that need and use this moment to accelerate that work. Marshalla, I'm sure you're having similar conversations internally, just like we are. Would love to hear about your views of what is unique about COVID that is allowing us to really dive deep into thinking about how to overcome disparities.
Similar thoughts, and unlike cardiovascular disease, diabetes, we saw in real time the effects of the COVID-19 disparities. And it wasn't just data. These were people's lives that people could touch and say, why are my family members and community members being more affected than others? That combined with the social unrest, George Floyd, it's made us think critically and look internally. It's made us strip down and say, look at the founding of our organizations, our institutions, and letting us know we cannot turn a blind eye. If we're not a part of the solution and if we're not going to think critically, then we're a part of the problem. And so I'm thankful that we're using this time to reflect, but not only reflect, make significant changes and meaningful changes for how not only are we partnering with our communities, but working to become a integral part of our communities. So ensuring that our communities don't only come to us when it's time for sick care, but that we're there for them for well care as well as assisting them with addressing the social determinants of health, because we know that we're only as strong as the sickest person in our community is. So I think we're all now identifying our role has to be a continued partner, continuously. And I remember in school, I'm not, Kara, if you remember, there was a diagram of the public health system. And and there used to be a hospital, there were pictures of churches, and there were other things in addition to the departments of health. So we have to go back to that diagram and practice holistic health care and remember that racism and bias are real and can't ignore them, but we must address them head on.
Rosa, you've been working in this space for a long time, creating innovation, working in, unusual locations with new innovative ways to reach very, very, very challenging circumstances and those who are navigating complex systems, but really coming for help. I wonder if you could also talk about what you've seen as unique during this time of COVID, undoing 60 to 70 years of disinvestment in Black and Brown communities is challenging unless you have resources. I wonder if you might share a bit about what has been unique during this time.
So one of the things that I think had a huge effect when we started doing with COVID-19 is that for many communities, and this is so true for the Latino communities, we're very family oriented. We will do things for our family that we would not do for us. So when you talk about diabetes, hypertension, it's about me, right? It doesn't affect anyone, it's about my health. But when COVID comes in, and now it's not about me, now it's about my grandmother, my mother, that I could potentially take this home and cause the death of my loved ones. That took a complete different spin on things. So I maybe wasn't, I hear about diabetes, but that's just me. I'll deal with it at some point. But now you're throwing something that is not just about you, it's about those that you love. And for our communities that are so family oriented, this was a huge and a big issue. And they wanted information and they just didn't know where to turn and get it as quickly as possible, right? And that it was from a source that they could trust. So that became a big issue. So for us, it became very important, again, to make sure that our staff understood, because these are the individuals that were going to go out there, and we needed to make sure that they would present that information as accurate as possible. We've been doing the news, as Dr. Luda mentioned, things were changing very quickly. So today we said, don't wear masks. Tomorrow saying wear a mask. And the next day, well, wear 2 masks. So all this information is changing quickly. So we needed to make sure that our staff was out there providing the best of the information that they could in a way, not only language, but in a way, in a cultural way that was acceptable, right, and understood. So that took some time because, like I said, we were changing our protocols from one day to the next day. Things that were simple in a lot of places is, facilities locked down. Only 1 person or 2 can come in. Well, that doesn't work for us. Why? Because our families tend to come in, the mother with 3 children, the mother and the child that's going to be seen, and 2 more and 3 more. So we couldn't say we lock our doors, only 2 people coming. No, that doesn't work. So we had to quickly change that to accommodate those needs and work with that. But the other big piece that we didn't talk as much, it was that mental health need. That became huge. And I can tell you that I was on the field, I was testing, educating, and to see a 6 feet tall man on one of those big trucks literally break down and start crying when he was told that he was positive, it was amazing to me. I mean, this was like a 250-pound big guy in tears. And when we stopped to ask him what was the issue, I have my 85-year-old father who lives with me, and now I don't know how to go home. That was his thing. I mean, we have a mother with 2 little kids in the car, in the back of the car, who comes in tested positive. She breaks down. What was her concern? It wasn't her, the 2 kids behind her sitting in the car seats. So it was immediately obvious to us that we couldn't just have people testing and educating about COVID. We needed mental health access at this testing and what we were doing all this education as well, because these were real things for the people that we were working with. So mental health became a big component. The social determinants, as Dr. Lee mentioned, was the other piece on how we dealt with this, because we know that in Sussex, there was an explosion, right? It was really, the Latino community got very affected by COVID. Well, why? Well, we know housing is an issue in Sussex. We have multiple families living in single units. We have individuals that couldn't go home with a mask because if the people that were living with knew they had COVID, they weren't going to be kicked out. These are not people that have leases and contracts to be there. They were going to become homeless immediately on top of being sick. These were individuals that are doing non-healthcare essential frontline work, that the poultry plants or the grocery stores. These are the ones that every day we're getting up. They weren't working from home. They are in the field working. That had to be addressed. And this is why we had these explosions. And how do we educate them about the mask and washing hands and all of that Elevata made reference to. So the social determinants, the mental health piece of all of this was also a big issue that had to be quickly addressed from a bigger perspective that we were already addressing. And then the education of our staff, and by that, I don't mean necessarily our providers and nursing, but our interpreters, our front desk, our transportation, our outreach people. A lot of times we find out that these are the individuals our patients tend to confine with, feel comfortable with sharing. So because the interpreter speaks my language, I feel comfortable sharing with this person. The front desk that I go and have another 5 minutes of social conversation with, that's who I feel comfortable talking to. So we had to get these individuals on top of this as well and provide them with the resources that they needed so they feel comfortable talking to our patients, whether on the phone or in person, to address some of the concerns that we're bringing up.
Thank you, Rosa. And thank you for mentioning the importance of mental health. I hope that others will comment on that. And I just reflect on the initial messaging around the standard refrain was stay home, stay home, wash your hands, wear a mask. And well, for so many of our communities, that message did not resonate, right? They couldn't stay home. They had to go to work. They had to put food on the table. And we had some resources to help with that navigation, but not enough, not nearly enough. And we know that food insecurity is still an issue, even this far along in the pandemic. But I do think that creates mental strain and mental health issues for not only families, parents, grandparents, but also our young ones. And we're seeing that at Nemours. I wonder, Levada, Marshalla, Martin, would you like to comment on the mental health impacts as well?
Right. At the level of public health, I think what I would say the signs of mental stress we see are usually related to the calls coming in for folks that are very frustrated about what to do. Initially started the testing when they could not locate testing or they could not locate their results, and you could hear in their voices that there are other things behind that probably they cannot talk about, but the issue that's bringing the stress to the top is whether it's the testing or whether it's the access to vaccine or access to vaccine for. And I think, as Rosa indicated, the fear of infecting or failing to protect your loved ones is something that I think is stronger than most of us do realize, because many folks would call in and ask about their 90-year-old father or grandfather or somebody who's aged, and you could see that there is need for mental health support out there. Definitely, there's a lot of it. Unfortunately, it's not something that public health was able to handle at that time. But working with our stakeholders and other community organizations, we hope that is being taken care of.
Certainly, that one of the things that the Delaware Medical Reserve Corps is providing is mental health first aid at the food banks that are out in the community. Many of the times that people access the various food pantries that are in the city, they come in with a great deal of stress around trying to secure enough food for their families, particularly in communities with food deserts. It has been really critical that there be someone there to at least guide them to professional services if needed, or sometimes just to be a listening ear so that they can unburden themselves at the moment of their issue instead of getting into a crisis situation. But certainly all of us can, and particularly the faith community, can provide some of the relief for distress in a number of cases. So those are the things that we are trying to do as far as addressing. NAMI has done a wonderful job in doing Zoom education programs and having virtual support groups that people from the community could access. So help is available. We try to impress that with our faith leaders calls with the Lieutenant Governor's faith leaders call that help is here. We still are dealing with a crisis with the opioid addictions. And we're trying to get our churches and congregation, our houses of worship open to let folks know help is available.
I think that the mental health implications of COVID, unfortunately, are going to be long lasting. Going into the pandemic, we had a shortage of mental health providers that has not been addressed. And we know that that depression, anxiety can be revealed in different ways. As a medical provider, I remember those stages that I went through when I was fearful about returning back to work. And just so many people were dependent upon their jobs just to make ends meet, that they were having to make the decision of, am I going to care about my life, or do I sacrifice food on the table for my families? And I don't know if we've resolved that concern and that issue with many families. And so, as Nurse Owens White mentioned, the importance of the church, and thankfully a lot of churches are having virtual services, so individuals who weren't able to go to sanctuaries are able to get assistance. But as we mentioned, and I've spoken to many churches, that it's still not enough. That we've been encouraging our pastors and congregations that in addition to what they provide, referring individuals for professional services has to also be a part of the plan. And so, as with everything, we're going to have to work together, do our best to recognize anxiety among our families and friends and support them and encourage them to seek care. But this is something that we can't sweep under the rug, and people are going to have long-lasting symptoms, and we must continue to address it and ensure that resources are going towards addressing the mental health implications.
Thank you for raising that critical issue. And I know that the state is working hard on our opioid strategy. Help Is Here is critical. And we're seeing, unfortunately, increased overdose deaths during this time of mental anguish and financial distress. Unfortunately, again, we have a lot more work to do around workforce and who can provide these supports. I want to pivot a bit because of our community that's listening here around our research and our engaged research. We know that engagement is critical to having more impactful research that is meaningful to our communities and our patients. I'll ask each of you to talk a little bit about how research and state data collection efforts can guide our decisions around equity, and whether that's tracking vaccine distribution or testing sites. I think there's a lot of power in data, in engagement, and how we come together. I'll first start with Martin to give a bit of a perspective around state data collection and how that can inform ongoing research needs, partnerships with this research community that's listening today?
Right. As I said earlier, DPH is data-driven, and virtually all policy decisions are based on real data. We gather demographic data on all the activities around COVID activities, be it testing or be it vaccination. Because it's a moving target. The data is coming in. Sometimes it may not be as timely as it would be, but we use what we have. And like I mentioned earlier, the current process for collecting data for vaccination activities is based on data collected on site, and the data then flows into our systems for to be tabulated and then presented. Sometimes there is a delay in that process, so that some data does take time to get into the system. The challenge we are facing right now, as I mentioned earlier, was that the data we have as of now is based on the phased approach of vaccination. So we can only say what the data is telling us. And of course, we have to take that in the context, knowing that the groups that were represented, for example, in healthcare, or be it over 65, or be it, I mean, the groups that have been addressed to date may not be representative of the state's population. So, looking at that for determining disparity has to be taken with that in mind. But of course, the disparity does exist, and as the vaccine becomes more widely available, we do expect that the data will be more representative, and the data is shared publicly through through our website, and folks can go there on a daily basis and check the status of vaccination and testing for their zip codes on My Healthy Community website, which is available on the DPH website. And if there are questions that require, if a researcher requires additional data for their work, they can reach out to public health, and we can always work with you to give you additional data as is allowable, because sometimes, because of the limitations of the data, we cannot share data below a certain number to avoid issues of invasion of privacy. So there's that limitation when it comes to release of data.
I'm so proud of the work that the Division of Public Health did to make sure that communities could see the lowest level of information available. I think it's incredible that you can go onto this website. If you haven't seen My Healthy Community, or gone on to log in and look at your geography and by breakdown, it is pretty powerful and very unique in our nation. There are very few places who have invested in that type of data accessibility. I think that this is an important question for all of us. I hope, Laveda, you'll also talk about how having data guides some of the ongoing collaborations that can take place, and make sure that we're having this lens and focus on equity and building community trust.
I'm so glad that the Delaware ACCEL program has been established so that the community could be more engaged in solving some of the problems that we're facing. But I think for overall, with our healthcare system needs to identify their own health disparities in their own systems, and what their needs are, and look at some of the health providers that they deal with in trying to reduce the disparities. And look at some of the providers that may not have the lens of, as Dr. Salma says, of community as opposed to egalitarianism. So we need to have our healthcare systems take a look at in their own closets and see what's hanging in there. Again, with the Delaware ACCEL program, has found that the partnerships are really key in addressing the healthcare inequities and trying to pull together the right partners around to have discussions and trying to close some of the gaps that may be between community and the healthcare system. One of the, I think it's a program of Robert Wood Johnson, is community solutions for health equity. We need more collaborative programming, a tighter collaboration with, say, United Way of Delaware and the YWCA and those programs in the community that are trying to address the elephant in the room, which is the racism. We have to do that. Otherwise, we'll be talking about this 30 years from now.
Marshalla, Rosa, I don't know if you want to also add comments to the need to have researchers and data informing ongoing efforts around vaccine distribution.
Yeah, I think that one of the groups that have been always kind of the information is not there. It would be our Latino community or Hispanics. Data has always been collected. Racial data has always been collected, but ethnicity has not always been collected, and that has been a challenge. And we have very little information when we're looking. We don't have enough information when we're looking at the racial disparities, right? But then when you take that level down to ethnicity, then you really don't have enough information. As a federally qualified health center, and we had 3 in the state, and I would dare say all 3 are great. When we talk about the Red Westside Health Services and Henrietta Johnson, this is information that we've been collecting for decades, right? Because we have to. It's information. It's sometimes I see when we are, at least with the pandemic, I saw that there was a lag of collecting that data at the beginning when we're doing the testing, right? So that it took a little to say, hey, we're missing this information. This is important as part of the testing. And then, with the immunizations, I think there we started right away, and that became important in terms of making sure that we were collecting that data. For us, is very important because we determined where communities we're going to go to. It determines the staffing that we're hiring. So we use this data of the racial ethnicity data. Is very important to us for the services that we're providing, for the staff that we're hiring, because we want a staff to mirror the communities that we're servicing. But it even impacts to our board level, right? We want our board, who sets kind of like our focus for us to be as diverse as our communities and the patients that we serve are. So data is very important, and look at it very strategically from that point. But also the data collected with that is to match, again, those social determinants, and how that data is also important to be collected, because it has a tremendous impact in terms of when you're looking at how effective you want to be in some of those health outcomes. The racial ethnicity alone doesn't determine that. You need that social determinants information and data to be able to mirror and make sure that you're actually creating the impact that you're looking for.
Marshalla, I'm going to pivot your question just a touch, because there are some great questions that are coming in through the chat, and I hope you'll continue to send them. We'll spend a bit of time with your questions from the audience, but there's a question about data collection, specifically around vaccination, and recognizing we need to get everyone vaccinated who's interested. How do we make sure that there's an ongoing engagement around research and discovery, thinking about long-term effects, benefits of the vaccine, and sharing that with communities? And there's a particular question in the chat about pregnancy and fertility, and I wonder if you have any perspectives on how to get more engagement and why it's important to not only recruit from communities, but also share this information back in an ongoing way.
Great question. In regards to that question of community engagement and research, we know that community engaged research, there's a spectrum. And a lot of community members were telling us, you know what, we're tired of being overly surveyed and people don't come to us for input until it's time for us to complete a survey. So really that community engagement spectrum is not just going to communities for input when it's time to do the survey, but the higher end of the spectrum is more the community led and the community participatory research. So what we've done as what I've done as a researcher is I've worked and embedded myself in community organizations such as the Metropolitan Wilmington Urban League, such as my sorority, Delta Sigma Theta. And so that what I do now is I'm not a researcher, but I'm assisting communities to conduct the research that they're most interested in. And most of the time is also meeting the needs of our institution and as my personal needs as a researcher as well. But that's one step and one strategy because they're saying that we're over surveyed. We don't mind assisting, but we're tired of completing these surveys and they're not meeting our needs. And the researchers aren't sharing data with us to tell us how it's impacting change to meet our needs. The next thing in regard to the maternal health, I know that there was a lack of data. There weren't pregnant women who were included in those initial clinical trials, but what we conveyed to the community is that we know that pregnancy is a risk factor for worse COVID-19 outcomes. And although there isn't sufficient data to recommend that it's safe, we do know that the harms of COVID are known. And so I'm thankful that there were enough medical providers and others who were pregnant and did the same thing that I did and said, you know what, there may be a lack of data right now, but I'm willing to ensure the safety for my community, and they got vaccinated. So early on, we were able to obtain data from healthcare workers who were pregnant and were able to see that the effects were pretty safe. And also during the clinical trials, despite the participants not being pregnant when they enrolled, a good number became pregnant during the clinical trials, and they were able to show that there weren't any significant known harmful effects from pregnancy. So just being able to be honest with communities, let them know that yes, we have a lack of data here, but this is what we're basing it on. And people just want to know that you're being honest with them and clearly communicate what's going on and communicate risk versus benefit. And I think the more that we've done that, people have been more willing to accept the risk of the vaccine. So just knowledge is power, and increasing the research literacy of our community so that they can make informed decisions is very important.
I wonder if you also want to touch, or someone else touch on, how you counsel patients about monitoring long-term impacts such as fertility outcomes, which we don't have a lot of data on right now.
Yes, so some things that we're doing, we know with the CDC, once you get the vaccine, they have the V-Safe monitoring system where they're collecting real-time information and data. And I explained to them that we now have a good number of months for pregnancy-related COVID-19 vaccine data is not sufficient to make a definitive recommendation, but that the CDC is on an ongoing basis evaluating it, and that they should just continue to have that discussion, open, honest discussion with their OB-GYN, their provider, to discuss risk versus benefits. But that there are a lot of eyes on it, and we're doing our best to ensure that there aren't any negative side effects of the vaccine, such as infertility.
Does anyone else want to add about how we make sure that as we get more data, we share that adequately with community?
One of the things that I learned was that in participating, getting the Black community to and the Latin community to participate in clinical trials, that in Africa and Brazil, there was a number of studies going on, but again, how does it relate to those of us living here in the United States? So I think along with education around the testing and the vaccine, is to encourage folks to get involved with the clinical trials. I was one of the ones in the let's wait and see how this vaccine goes with folks before I got a vaccine. And of course, being convicted by my faith, I had to have a long talk with the source of my being about getting the vaccine, to the point that I actually entered into a clinical trial so that the community could best be served. So I think educating about what clinical trials is all about, what the efficacy of vaccines that are coming out, because now more manufacturers are coming up. This one's producing a vaccine. In addition to Moderna, Pfizer, and Johnson and Johnson, people are going to want to know, well, how safe is that? Is this still in an experimental stage? So the education is really very critical to our community.
Right. I think we can't overemphasize that education piece, because it is a fact these vaccines have come out pretty fast, and the CDC has in place. I think one thing that has to be emphasized is that the CDC has in place a long-term processes for long-term study of the effects of these vaccines. For example, the vaccine adverse events reporting system, which collects all adverse events, regardless of whether they may or may not be related to the vaccine, and then eventually tabulate millions and millions of data to come up with the possibilities and things that can be disregarded straight off. So I think this should be of comfort to the patients, knowing that there is ongoing assessment of the safety of these vaccines, and all information will eventually be released.
Thank you. I think there are actually some wonderful comments and offers for help in the chat right now. There are two. One is, do you need students to get involved? And I would love to connect with you afterwards to find out ways to either work with you on efforts or projects. So I hope that we can share participant information later, but for any of you who think a student may be helpful for your work, please feel free to share with this group. I think there are many who are interested in thinking about projects, research questions, outreach strategies, and the like.
This is Marshalla. So one of the things that we've been doing is distributing community COVID-19 safety kits that include masks, hand sanitizer, and other supplies, again, to meet immediate needs of people. Because once people see that you care, they're more willing to work with you and understand what your longer term strategies are. And so if you have students that can be extra hands to assist us with preparing those kits, I would love to have them. Unfortunately, right now, there isn't a lot that we are doing virtually in regards to our research. But I know that even our elders, many of them would appreciate phone calls and engagement. And so those are some things that the students possibly could be doing to assist virtually as well.
I want to back that up, because I think that we still need some research investigating spiritual well-being. And we need some insights from research to explore subjective and objective aspects of the quality of life, particularly living with this pandemic, whether it be the racism, whether it be the opioid, whether it be COVID, that we need to have a measure of some sense of meaning and peace, and the role of faith in illness and trauma. That's something that the students could take on.
I think later on, once the pandemic has settled down, if I may use that term, we may be able to use student interns. But at this time, I think in public health, we are too busy to handle any student at this time.
I wish that there was somehow a way to really spread out more information about research, clinical trials, what it is, what it means, how to get people involved. There's such a low participation from the Latino community on those on research. And it's just because I don't think that there's been much of an effort to include that community or maybe not how to reach properly the community that has not led to that. So it would be nice to just somehow, I don't know if that's something students could do, is how to go about to reaching out, specifically in this case, the Latino community, to include them. What is research? What does it mean? What happens when you participate, right? What are the challenges or the opportunities when you do that? There's not enough information for this community to participate. The other thing that we've had gotten some volunteers to help with is for our communities, when we talk about, Latino community, the immigrants, we can't do Zoom visits. We can't do, these are people that we have to go and knock on the doors. It's as simple as that. Like I said, there's a challenge with phones and things like that. So I know that our case managers have been so busy in the last 9-10 months because that's just what it's taken. They are amazing people because these are the individuals that, despite when everybody, I compare them to the firefighters, right? When everybody's running out, these are the individuals that are running in to help. So despite, the whole COVID and infectious rates and all of that, they were literally going out and finding out, do people have food? What was the need? What did they need to do? Educate them at their homes. We had the care kits as well. But it was important. It wasn't so much that we didn't think people didn't have paper towels or didn't have this. It was that it was the opportunity to educate people how to properly disinfect and how to properly use these materials, right? So that they can think about maybe things that they weren't thinking about. So, it's not just to clean a surface, but go to your doorknobs, the faucets, clean those as well. So it was more of an education piece. It gave us the opportunity as we were sharing these things to explain how to properly and the best way to use this. So that was very, very key at the very beginning to properly explain these things to people as well.
Thank you, Rosa. That was actually a question in the chat around at 8 to 9% of the Delaware population, immigrants are a small but not insignificant part who has been impacted by COVID. And so you shared a bit about what Loretta's doing around working with immigrants, but I wonder if others want to share about how you're working directly with the immigrant community in Delaware.
Right. I think traditionally we have worked with immigrant communities in vaccination activities, specifically the seasonal flu vaccine, and we reach out through specific materials prepared for those communities to the Haitian community and the Hispanic community as well. So this is a group. These are groups we are very used to working with, and we have rolled that activity over to the COVID as well. So we have produced materials specifically for these groups, the Haitians and the Hispanics, for the COVID vaccine testing and vaccine as well.
And I'd like to add to that because it was also figuring out it wasn't only providing those materials, right? Mm-hmm. Some of those we had to make them graphic because people cannot read. We have a lot of people that cannot read. We have a lot of immigrants that Spanish is not even necessarily their main language. They have native language, right? So Spanish, you're given something in Spanish, they still don't understand it. So graphics became very important in terms of wearing your mask, social distancing, washing your hands, and making some of this key education points that we're trying to get across on a graphic way, so they at least could see a picture and understand what we were trying to say, or take it home and kind of share it with their parents, and the parents kind of follow the idea of what was it that we were trying to get accomplished with the message.
And Christiana Care formed a very strong partnership with the Latin American Community Center early on in the pandemic, and it's now a permanent COVID-19 testing site. But we're also partnering with the state and community organizations to host specific vaccine events for different racial and ethnic community, immigrant communities.
So as we start to think about wrapping up, I wondered if we might spend just a round robin closure in the one piece of advice you each would give the audience in developing community engaged research projects around COVID-19 specifically. I think of the Delaware CTR, our work as matchmaking. So there are lots of comments in the chat right now around, can I reach out to you? I have an idea. I want to think about things together. And I think that's the role that the CTR plays, right, in making sure we have those forums for connection. But one piece of advice that each of you would have would be wonderful. Levada, we'll start with you.
Well, my advice would certainly be for everyone to become a card-carrying member of the NAACP. You want to make a difference, join and help us to provide the education. And, you know, if all of us, it's like during the civil rights time when we had to lock arms together in order to overcome the racism that was prevalent at that time. We're back at that stage, and we need all of us to come together as one body, as one informed, solidarity, just come together to say that these inequities we will not tolerate anymore. This violence that's in our communities, we won't tolerate anymore. The climate change that is happening, we're not going to tolerate. All of us have a part to play in making our communities, our neighborhoods, our world a better place. We've forgotten some of those lessons that we learned in civics a long time ago. We're so busy trying to build ivory towers and the bigger and better houses that we've separated from our neighbors. We need to come together again. Come together, children.
That was powerful. Marshalla?
Yes, that as researchers, we can't stay in the ivory towers. We must become active and involved, engaged members of our community. And if we're going to partner with our community on research, which we should be doing, we must involve them early and develop meaningful, mutually beneficial relationships with them so that the next time a researcher comes back to partner, that they'll be eager to do so and that they won't be burnt and that this won't tarnish ongoing relationships with researchers.
Martin?
Yeah, I think what I would say is that the researcher should engage the community as deeply as possible so that they understand the reasons behind the research and how they would stand to benefit from it. Because I think one of the refrains we hear a lot is that we are over-surveyed. And that means that folks feel that people come in, take data and leave, and they never know what happened to it. So I think the researcher needs to know that the community should be engaged early and fully so that they understand the reasons behind the study or the survey, and that they make sure that they get back to the community with useful information that it's not just information, that information that they can use to improve their health and their positions.
And Rosa, do you have advice for the audience today?
I would have to agree with that, Tallulah, about really embedding and reaching out, but also coming back. I think that's been one of the challenges, is that a lot of times either the information doesn't come back or doesn't come back in a way that those that were in those part of those trials or research understand it or can apply it or is meaningful to them. So also, kind of explaining or showing, being able to show, this is what has been done in other places. Go back to the Latino community, where in other places have heavily the Latino community having research on, what researches have been done with, where it has had an impact, a positive impact as a result of that research. This is the change, and this is what we saw that was clear and effective in the Latino community. So when you're able to show some of that, then you're probably going to have more people willing to be engaged because that's something to compare to. Out of the blue, people are not going to participate. They're just not. The trust issue is huge. And specifically when we talk about the Latinos and the immigrants, the other component to understand, and Levada may may talk about the challenges, you know, and the disparities and the racism that exist, we have two bags that we carry, right? We have the bag that we bring with us from that country we came from, where we were mistreated. You know, we had the crimes, the violence, you know, all of those things that we carry with us. And then we get here and then we have to deal with a separate issues, maybe not as similar, but still with that disparity and that lack of trust. So that we typically carry two bags, and those bags kind of have to be addressed. We can't take care of one without addressing the other one, because that's what made us who we are. That's why we have the lack of trust. So that's why we don't want to go here or do this or do that or provide this information. So both of those bags will have to be addressed.
Thank you so much. So with that, we'll conclude this panel. There is a link in the chat from Karen Hugh to show you how to actually engage with the community or connect the dots between panelists or others who can guide you in your research project development. Dr. Sanders.
Well, I just want to thank the panelists for a very informative, useful, and on-point discussion. The discussion did exactly what the planning team wanted the panel to do, and that was to amplify some of the main points of the keynote speech. I'm not going to say more because we are on the timeline. We are going to break now, and we will resume at 12:30. Thank you again.